Good morning. This is a singular honor for me to stand here in this distinguished meeting and give the ISCCM oration. And I thank Dr. Chawla and the entire ISCCM Executive Committee for conferring this honor on me. It is a rather young age at which to get this honor, and I assure you that I'm not going to be a has-been after this, and will be continuing to do some work in intensive care even after. Now, I decided to speak on the cancer patient in the ICU, a clinical and an ethical challenge, and that's because I have worked for the last several years in a hospital which is the major tertiary referral cancer center for our country. It's a 560-bedded hospital for cancer. We have a 23-bed intensive care cum recovery room and a 14-bed high dependency unit, and that's the nice unit which you can see hidden behind the trees, but it's a concrete jungle out there. Now, cancer has become very fashionable to treat cancer because cancer treatments are improving. Oncologists have new drugs, they've got new protocols, they've got very intensive protocols. We've got several new drugs which have come up in the last 15 to 20 years. We've got improved diagnostics for supportive care, for detecting opportunistic infections. We've improved the management of several problems. And as a result of which, mortality from cancer, the prognosis of cancer, especially hematological malignancies, lymphomas, has dramatically increased over the last few years. Oncologists have become more optimistic. They're giving more and more chemotherapy. They're giving more and more drugs. They're getting more and more aggressive in their approach. They're blasting patients with drugs. Outcomes are improving. Even in our institute, the outcomes in acute lymphoblastic leukemia have improved significantly over the last decade. So the overall survival, which was just about 40% in 86 to 89, in 98 was almost 75%. As a result of this, we are getting more and more admissions in the intensive care unit. We are getting more and more patients with hematological malignancies, lymphomas, who previously never came to ICU. So in our own intensive care unit, in 96, about 15 years ago, only 3% of patients were from the hematological oncology side. And they've steadily increased over the years, and today they're almost 25% of all admissions to the ICU are malignancies. The Indian Intensive Care Case Mix and Practice Pattern Study, which the ICCM is doing, the INDICAP study, is a multi-center all-India observational one-day point prevalence study on 4 different days of the year. We have data of 2 days, that is the data collected on July 14th and October 13th, 2010. And in this study, we had 2,196 adult patients, and 5.5% were cancer patients. Hematological malignancies were 15% of cancer patients. And as you can see, the mortality of patients with cancer was almost double that of patients who did not have cancer. The hospital mortality of patients with hematological malignancy was over 60%, and more patients with cancer presented with sepsis, severe sepsis, and septic shock than patients who did not have cancer. So patients with cancer are definitely sicker to treat, they have a higher mortality, and their outcomes, especially with hematological malignancies, may not be as good as with other patients. So why does a cancer patient come to the ICU? The simple ones are the post-operative patients. They have major surgery, but they're relatively easy to manage. They need monitoring, they need ventilation for a short term, they need more nursing, treatment of their comorbidities. They come with complications due to disease, complications due to treatment, and this is something which is peculiar in a cancer patient. The drugs that are used and the treatments that are used to treat cancer are themselves so toxic that they require intensive care by themselves. And of course, they can have acute illness unrelated to cancer. Now, in our own hospital, when we saw the data from 2004 to 2005, if you can see the patterns of organ failure, the surgical patients in light blue have virtually hardly any organ failures. The ones who have solid tumors, with medical oncology with solid tumors, have a significant number of patients have organ failures, but the hematological malignancies, a large percent of patients have severe organ failures, and they have respiratory failure, they have severe coagulation failure, they come with severe coagulopathy, they have very low platelets, they also have cardiovascular failure. So again, you can see the hematological oncology are the sickest ones and the most difficult ones to treat. So some of the typical cancer syndromes that we sort of see in the intensive care unit, this is this man with acute myeloid leukemia, with fever, after chemotherapy. He's been treated in the ward for 5 days, he's been admitted, but he's got unremitting fever, he's become worse, he's become tachypnic, he's become tachycardic, he's hypotensive, he's got a lousy hemoglobin, absolute neutrophil count is just 300. His platelets are down to 6,000. And this patient is a febrile neutropenic with septic shock and probably one of the most difficult patients to manage in the ICU and probably ones with the worst outcomes as well. These are some of the common metabolic syndromes that you see in the intensive care unit in cancer patients. And this is a patient with a cancer of the pharynx, and he's been treated. He's already finished his treatment, but he now presents with fatigue, anorexia, polyuria, weakness, and his X-ray looks shocking. And this patient got hypercalcemia. And hypercalcemia is a reasonable common metabolic abnormality. It's done in almost 20% of cancer patients. And you have patients both with solid tumors, especially in the breast, lung, prostate, and multiple myeloma can cause these sorts of cancers. And this is important to diagnose because even though they've passed treatment and they look like they're pretty advanced, they're relatively easy to treat. And with simple hydration, simple hydration and reduction of the calcium levels and maybe dialysis in extreme cases, you can actually salvage a lot of patients. The tumor lysis syndrome is another important metabolic problem that is seen in the intensive care unit. And again, it's seen with rapidly growing tumors, especially after chemotherapy for very sensitive lymphomas and leukemias. And again, this today is very easy to treat, especially with hydration, alkalization, diuresis, and drugs like rasburicase. So there are patients who are very difficult to treat, and there are patients in whom you can treat pretty well and get reasonably good outcomes. Shock is a common problem. In cancer patients, you can get septic shock from a variety of reasons, including surgical problems and febrile neutropenia and hemorrhagic shock, but you can also get shock from cancer-related problems. And these relate to cardiac tamponade due to invasion by pericardial metastasis in various cancers. You can get because of the effects of radiotherapy, because of the effects of high-dose cyclophosphamide. You can get acute adrenal insufficiency, either causing shock or worsening the outlook of shock, and that can happen from adrenal metastasis. Like we have adrenal tuberculosis in this country, which is often seen. You can have adrenal metastasis, especially in breast cancer and some of the GI cancers. And these patients may need steroid therapy to, in fact, improve their outcome. Hypersensitivity reactions occur to various agents, and some agents are themselves cardiotoxic. You can get bradyarrhythmias with paclitaxel. You can get myocardial ischemia and myocardial infarction. You can get with drugs like 5-fluorouracil. And it's caused by coronary artery spasm, and it also causes myocardial dysfunction. So you can get syndromes which look just like a myocardial infarction, but which may be due to the drugs that have been given for cancer. The anthracyclines, adriamycin or doxorubicin, they are very well known to cause cardiac failure. You get chronic cardiac failure. Patient who's had anthracyclines in the past can present with chronic cardiac failure, complicating some other condition that they've come with. And you can get acute and subacute cardiac failure with the anthracyclines. So you have a whole load of drugs which can cause cardiac failure and cardiac complications. And you need to consider this when you have a patient with cancer presenting with shock and hemodynamic instability in the ICU. Respiratory distress is a very common indication for ICU admission. And although very many patients have infections, and these infections are not necessarily simple infections, they can be bacterial, but they can have PCP, or pneumocystis jirovecii as it's now called. They can have aspergillosis, they can have other opportunistic infections, CMV pneumonia, and we need to diagnose and treat all these conditions because it is well known that if you can diagnose and treat the cause of respiratory failure, the outcomes are not bad. If you do not have a diagnosis and you are not able to give the right treatment, the outcomes are much worse. But there are also cancer-specific conditions which cause lung infiltrates and which cause respiratory distress and hypoxemia. And these include tumor emboli, diffuse alveolar hemorrhage. In patients who have got undiagnosed or untreated leukemia, they can come with pulmonary leukostasis, where you've got the white cells sequestering in the lung and causing pulmonary infiltrates and hypoxia. In patients who have been treated for leukemia, you can get lysis and pneumopathy. Because of that, you can cause lymphangitis and you get all sorts of things. And drugs like bleomycin, busulfan cause pulmonary infiltrates, and they give you a picture like ARDS. Atra, which is used in the treatment of promyelocytic leukemia, is a very interesting drug because it causes multiple organ failure, renal failure, pulmonary infiltrates, edema, cardiovascular problems, just like multiple organ failure, but it's drug-related, and these patients can often be salvaged with a short period of intensive care support. So in our intensive care, when we looked at the medical oncology patients, not the surgical ones, like I said, they don't have much organ failure. They're relatively easy to treat. That's not a big problem. Their outcomes are almost just like any other patient that you see. But some of the medical oncology patients are very, very difficult. And if you put the hematological and the solid medical oncology patients, in our ICU in 2006 and 7, we had a 70% mortality. And that was pretty high. And we'll go into why the mortality may be high and what we can do to reduce the mortality. Patients who do not require ventilation do not have a high mortality. It's just about 10% in the ICU. The patients who had non-invasive ventilation had a 30% mortality in ICU, going much higher in the hospital. But if you required mechanical ventilation, then the outcomes were extremely poor. And because the outcomes are poor, the costs are high, and the cost per survivor becomes very high, especially for the hem-onc patients. And this is some data which we had got from my colleague Atul Kulkarni, who had done this audit. A surgical patient spends just about 26,000 rupees, but this was in 2006 in the ICU in our hospital. A medical patient spends 4 times or 5 times as much. And the cost is the cost per survivor. So the cost per survivor obviously going to be high if your outcomes are not going to be very good. So this is a sort of essential dilemma that many people face. In general hospitals, you've got patients with cancer who've got problems, but you know that the outcomes are not going to be good. You don't want to admit them. You're reluctant to admit them. You say, oh God, what are you going to do? And then someone's pressurizing to admit them, but you say, oh, this is hopeless and there's no point in doing this. In a hospital like ours, which is a cancer hospital, we have to take all patients. Many patients are similar. And the patients that we have to treat, no other hospital is going to take. And so we are sort of stuck with some sort of patients that the oncologists are treating and we need to do. But at the same time, we do recognize that there are patients who've got reversible, treatable conditions, and we admit patients, even if they've got a palliation, not necessarily cure, but even if they've got a good chance of palliation, we would admit to the ICU. You need to consider the patient's wishes, and you also need to look at distributive justice when you're dealing with the number of beds. Over the years, what has been noticed is that the mortality from cancer has gone down. The mortality in intensive care, the ICU outcomes. We have the sepsis bundles, we've got the surviving sepsis campaign, and everyone is now very aggressive with fluids and resuscitation and early antibiotic therapy. And this was this paper from France, and which showed that in patients with hematological malignancy and septic shock, they had a 30-day mortality of 65%, which is very high, but for a febrile neutropenic, that's not very bad either. The factors which seemed to improve outcome was time to administration of antibiotics. Less than 2 hours was a bad feature. Use of appropriate antibiotics was a protective feature. But they also said that early admission to the ICU, fewer admissions with poor chronic health status. In other words, there was a selection of patients over here which was taking place. So you select good patients. You don't take patients who have got poor chronic health status. You take reasonably good patients, treat them early and treat them aggressively and appropriately, and you probably have better outcomes. And they also commented that increased use of non-invasive ventilation. And we'll come to non-invasive ventilation soon. We've got better diagnostics for respiratory failure. We've got better diagnostics for viruses. We know at what stage, what are the problems that are most likely, and we can focus our investigations. We've got very good non-invasive diagnostics. With CT scan, high-resolution CT and molecular tests, we can diagnose a large number of infections, and that is going to contribute to better outcomes. Patients are given chemotherapy in the intensive care unit. So patients come with, so this is a paper again which came from Elie Azoulay's group from France, and these are patients who had undiagnosed or newly diagnosed untreated cancers, and they landed up in the intensive care unit with organ failure due to some cancer or some tumor, and those patients were admitted in the intensive care unit and given chemotherapy in the ICU. And these patients did very well with a 60% survival at 30 days. In our ICU, we get a lot of patients with mediastinal tumors, and they come with superior velar compression and airway compression, and they have airway obstruction. And airway obstruction cannot be just simply managed with endotracheal intubation. It's very hard to ventilate, very hard to maintain the airway, but many of them have tumors which respond to chemotherapy. The lymphomas respond to steroids. So you can use, so we are given steroids, they're given chemotherapy, they have a trip to the CT scan to get a biopsy, Very difficult to manage, but with chemotherapy in the ICU, you are able to salvage some patients. And if you can get the patients, relieve the obstruction, extubate them before neutropenia and the problems of chemotherapy set in, you can give them a reasonably good outcome. Now, one of the big advances in the management of cancer patients has been non-invasive ventilation. And this was first suggested in this paper, again, by Azule's group. And they had a retrospective study of patients with hematologic malignancy. And when they did a matched pair analysis of patients who received non-invasive ventilation versus those who received invasive mechanical ventilation, they found that patients with non-invasive ventilation did much better. Their mortality was only 40% versus 70% with patients who received invasive ventilation. And they did a multivariate regression analysis, and they showed that non-invasive ventilation was an independent factor predicting survival in these patients. And this impression was sort of confirmed, virtually confirmed by this small study in immunocompromised patients from Hilbert, which was published in the NEJM. And these were 52 immunosuppressed patients who were randomized to NIV or no NIV. And 30 of these had hematologic malignancies. And again, they demonstrated very good outcomes, avoidance of ICU mortality, avoidance of intubation in patients who received non-invasive ventilation. That sort of set the stage for non-invasive ventilation in immunocompromised patients with cancer. A very recent paper said that if you gave patients CPAP on the wards early in the course of the disease, before they had evidence of pneumonia, before they had evidence of sepsis, before they had any hypotension, you gave them CPAP. If they just had respiratory distress, little breathlessness, you give them CPAP on the wards, and you could actually prevent the evolution of their respiratory failure. If they did not require as much ICU admission, they of course had a much lower mortality. So there we are looking at a spectrum of illness, very early presentation, and some patients who require non-invasive ventilation in the ICU and who seem to be doing very well. But we also had a study that this year or last year from a group in Belgium, which is well respected and well published in cancer. And when they put forward their results of non-invasive ventilation in cancer patients, they found that patients who had non-invasive ventilation within 24 hours of admission in ICU had a 70% mortality, and those who had invasive ventilation had a 63% mortality. So no difference between invasive or non-invasive ventilation in some cancer patients coming to the ICU. So it's not that non-invasive ventilation is a panacea. And when we saw this paper, I was personally very relieved, because just before that I had looked at our results of non-invasive ventilation. And of our 326 medical oncology patients in 2006-2007, 100 patients had been given non-invasive ventilation, and the ICU mortality was 70%, similar to what the Belgian group had found. Success with NIV, meaning not requiring intubation, was seen in only 30% of patients. And these patients had a mortality of 30%. And if any of these patients required intubation, the mortality was 90%. And we were very stunned when we saw this. We thought NIV would be doing very well, and that's before we did the Belgian paper. There was no difference in when you compared patients who succeeded NIV and those who failed NIV. There was no difference in the initial severity of illness, the organ failures, or the time to ICU admission. But what was really different was the change in organ failures. So if you can see, the blue graph is the change in organ failure score from day 1 to day 2. It's gone down. That means improvement in organ failure. And same thing in day 3. That's delta 2, the green graph. That is the day 3 organ failure score minus the day 1 organ failure score. If they have decreased, they succeeded in NIV. If they've increased, then they failed NIV. So it's not the severity of illness or anything. It was the progression of organ failure which seemed to make a difference to success or failure with non-invasive ventilation. And why did we and maybe the Belgian group get poor results? Maybe we are not very good at it, but the Belgian group certainly is very good. Maybe the patients were too ill. There's a big difference between the patients in Hilbert's study, the randomized controlled trial, and the Belgian and our study. Maybe the underlying cause of a respiratory failure may not have been treatable or reversible or diagnosable, and there has been, as I said, progression of organ failure. We also have to worry that maybe we are trying non-invasive ventilation too much, too often in too many patients, and delaying intubation in some patients. That's another possibility. So what has changed? What else has changed? Of course, sepsis, maybe non-invasive ventilation, but now this is again a paper from Azule, and this is a very paper which gives you good insight into why outcomes may be improving. So these were myeloma patients between 92 and 98, okay? And what they divided the patients into two sort of time periods, those who were admitted before 95 and those who were admitted after 96. And if you see that the mortality is dramatically different in the two groups, it's 75% in 92-95 and 35% in 96-98. The more patients got dialysis in the latter period, so they were probably sicker. More patients got non-invasive ventilation. That's another indicator. But the patients in 96-98 were sicker. Their SAPS-2 score was higher. So in spite of the fact that they were sicker, they got more dialysis. They, of course, got more non-invasive ventilation. Their outcomes were better. And that is given by the first line, that is a now scale C and D. So these patients who had a poor performance status, C and D, the poor performance status, was 67% at poor performance status in the earlier era, but in the later era, only 38% of such patients were admitted. So there is a selection of patients which is taking place, and leaving out patients who got very poor performance status may be contributing to better outcomes. And I think we'll see something like this in our ICU itself. So like I showed you earlier, in our ICU, the proportion of hematological malignancies as a percentage of the total ICU admissions went up steadily from 3% in 96-97 right up to 25% or even 30% if you take some other patients in 2006-2007, and our mortality zoomed up from 46% to 77-79%. We then implemented a very strict policy, of course in consultation with the hematologists and the oncologists, and we implemented that policy very well in the last 1.5 years. And now our percentage of ICU admissions of hematological malignancy is down to 17%. We have also started selecting our patients, and in the last 6 months of last year, our mortality was down to 53%. So maybe selection of patients has got something to do with it. So ICU outcomes for cancer have improved. We definitely understand respiratory failure and sepsis and general supportive care is much better. Chemotherapy in the ICU may contribute, but better selection is a very, very important feature. So how well do we select patients for intensive care? So earlier we used to say, oh, this patient is not very good, he's got advanced cancer, he's got something like this, let's not take him. Oh, we'll take, this patient's too good. He's just got a respiratory of 20, there's no hypotension, let's not take him to ICU. So we used to have very loose criteria or subjective criteria for ICU admission. So again, Azule's group did this sort of very nice study, and they looked at patients who were denied ICU admission. So almost half the patients for whom ICU admission was requested were denied ICU admission. And then they followed up these patients who were denied ICU admission. 54% were thought to be too sick to benefit from intensive care. 47% were thought to be too well to deserve intensive care. In the patients deemed to be too sick for intensive care, 26% survived. In the patients thought to be too well for intensive care, 21% died. And there was, of course, a greater mortality when they were subsequently admitted to the ICU. But in other words, with our criteria, our way of admitting and selecting patients for intensive care, we were wrong in almost 25% of times. So 25% of patients who may have benefited from intensive care were denied because we did not have good criteria for admitting patients. So how should we get criteria? So like many other groups, we did this analysis of predictors of ICU outcome in 326 medical oncology patients. And there were a number of factors on univariate analysis which stood out, including whether it was relapse or recurrence, whether the score was high, age, comorbidities, type of cancer, stage of disease, neutropenia, whether required ventilation or inotropes. So when you did a multivariate analysis, put everything together, only 3 things stood out. And only requirement for mechanical ventilation, organ failure on day 1, and progression of organ failure on day 2 and 3 predicted ICU outcome. In other words, none of the pre-admission factors seemed to predict ICU outcome, and you actually had to admit a patient to the ICU, see what happened, and then you would know whether this patient was going to survive or die. So it was the progression of organ failure and progression of severity of illness that seems to make a difference, and that can predict outcome. And that's the problem. Okay? And that is the problem. Because you then have to admit the patients, give them a trial. So this is the concept of the ICU trial, that because our pre-operative or pre-admission criteria are far from infallible, and because if you don't admit, you'll be wrong 25% of times, there is a stronger correlation between number of organ failures at admission and the evolution of organ failure in the first 3 to 5 days of the patient's ICU. Therefore, give them a trial of intensive care and then decide what to do. Now, again, Azule's group published the results of an ICU trial. So they had a policy where some patients, if they were absolutely fine, they got full treatment, and they had a 32% mortality. Some patients, they could not make up their minds. They did not meet the criteria of being fantastic for treatment. So there were 188 patients who got an ICU trial. In these patients, the overall mortality was 78%. So where they could not obviously select out patients based on the pre-admission criteria, their mortality was 78%. And this sort of compares with our mortality of unselected patients of 70% in ICU and 79% in hospital. So now we know that if we have to select a patient for ICU, how do we do it? If there's a request for admission, if the patient is bedridden, he's got very poor functional status, there's no treatment available, he's finished all his treatments, there are no new drugs or molecules that are going to be tried for him, he should not be admitted, he should get palliative care. He should not be denied care, but he should be given palliative care. If the patient has got newly diagnosed treatment, is in remission, he's for aggressive treatment, he should get full treatment in intensive care with whatever support that is required. All other patients should be given an ICU trial. Should be given an ICU trial for a limited period, give full treatment for a limited period, see how the patient responds, see how his organ failures progress, and then you decide what to do. And that is again a problem. If the organ failures are not progressing, what should you do? Should you pull out? Should you withdraw? Should you limit treatment? Should you continue in treatment endlessly? And a lot of people have this dilemma once you admit a patient to ICU. The ICCM has given a very nice position statement on termination of futile treatment to patients when patients. So this is a very good guide which doctors can use to limit or withdraw treatment. And we often limit and withdraw treatment. Now in our ICU, this is data which we have from 1.5 to 2 years. We have 38% of deaths were due to limitation of treatment. I suspect it's much more, but 38% were reported to the investigators. Most of the deaths were in the form of withholding treatment. 73% was withholding of life support. 27% we withdrew treatment. Withdrawal of treatment in our ICU is most commonly turning down the FIO to 21% and stopping of the inotropes. And in patients who've got progression of organ failure, who are getting worse and worse, this is a very sort of, patients we can withdraw treatment quite effectively in these patients. In the INDICAP study which we did, in the data which we have so far, you can see that the limitation of treatment is not very common at all. But there are differences between patients who have cancer and who do not have cancer. No CPR orders were given in 7% of patients with cancer and only 3.5% without cancer. Limitation of treatment was done in 17% with cancer and 6% without cancer. So again, physicians in India are not averse to limiting treatment, at least in cancer patients. Withdrawal is not very common, though of course much more common in cancer patients than in non-cancer patients. And LAMA is similar in both cancer and non-cancer patients. So people practice LAMA quite frequently, but when it comes to limiting and withdrawing treatment, they tend to do it much more for cancer patients than for non-cancer patients. So ladies and gentlemen, I just want to wind up. In the 80s, because we had poor outcomes, the philosophy was, if you have a cancer patient wanting to come to the ICU, just say no. Then, when we understood treatments better, we understood cancer better, we said consider saying yes. And today, with the concept of the ICU trial coming up, do everything that can be done, but select the patients for ICU admission and give them an ICU trial. I want to thank a lot of people in my unit, in my hospital, who've contributed to this data, who've worked with me for many, many years. All our nurses, our technicians, our physiotherapists, our residents, and of course our patients, and not to forget my family. I thank you all very much for giving me this honor once again and for a patient listening.